Good morning and welcome to the Caregiver Teleconnection. My name is Glenda Rogers and I'm going to be your facilitator for today's call with Dr. Tam Cummings. And we are going to be asking Dr. Cummings any kind of question that we may have having to do with dementia, caregiving of persons with dementia, just any situation that you may have in your caregiving journey that you want to ask her about. This is a rare opportunity, so I encourage you to ask those questions. Our session today is brought to you by Vitas Healthcare. And Vitas provides hospice services nationwide. Here in Texas, they are in Dallas, Fort Worth, Houston, and San Antonio. And on my little map, I see they're in California, Florida, and a lot of states here in the United States providing hospice care. Their telephone number, should you wish to talk to them about hospice care, is toll free at 800-723-3233. Excuse me. Let me repeat that. 800-723-3233. So I want to thank Vitas for sponsoring our session today. Before we get started, let me tell you a little bit about Dr. Tam Cummings if you are not familiar with her. She founded her company in 2009 with the mission to inspire, educate, and empower dementia caregivers. Now her professional gerontological practice in the Texas Hill Country is recognized as one of the leading educators of dementia caregivers and program design for dementia care nationally. Welcome, Dr. Cummings.
And thank you, WellMed, and thank you, Vitas Healthcare, or hospice. Hospice is, I think, sometimes so frightening to families. They see it as death is imminent. And it's really something that should be in place the final 9 months or year of a person's life. And it breaks my heart when I see a family, they get hospice and 2 days later, their person's gone. The hospice hadn't even had time to set up yet. So don't be afraid of it. When your person with dementia begins to decline, ask for a hospice order and talk with your Vitas group in your area. Hospice people are special, and we all should use them. Our tax dollars pay for them, so let's use them.
Absolutely.
Okay, I'm ready, Glenda. The purpose of this today was to give folks that may not feel like they normally get a chance to ask more detailed questions about their loved one, rather than I'm just giving you a presentation. So we were hoping for a little bit larger audience, but hey, this is going to be perfect. We've got just the right number of people here. So I think Leanne is going to start us off with a depression question.
Absolutely. Leanne, please go ahead and repeat your question.
Okay, thank you. My mother is 83 and she's very, very forgetful. We don't have an official diagnosis yet, but I've talked to her primary care provider and recommended that he send her to a geriatric neurologist. And one of the former webinars that I had listened to with Dr. Tam, you mentioned that depression mimics dementia, or maybe it's the other way around. But so I'm hoping that the neurologist will address that. Do you have any further advice?
Yeah, I've already sent Minerva the geriatric depression test. It's called the Geriatric Depression Scale, or the GDS. The only place it says the word depression is in the title, because your mother's part of an age group of people that overall don't see depression as an actual disease. They see it as a lazy person who just needs to get up and try harder, and don't recognize that it's actually an imbalance of serotonin in the brain, which is our main mood drug that our brain makes. So it's vital to us being well. Depression in the elderly, or depression itself medically, is also called pseudo-dementia, because a person with depression will appear to have cognitive challenges or cognitive difficulty. They won't remember things well. There will be short memory term issues. And we now know that about 10 years before dementia and actual cognitive impairment begins to show in a person, that 10 years before that, we see depression that often goes untreated. So it's critical. And the person you're looking for is not a geriatric neurologist. It's a neurologist who specializes in dementia is what you're looking for. Okay. And the neurologist normally doesn't do the depression test. That's normally done by a geriatric psych person. But I have sent you the geriatric depressions test. You can give your mother this test over the phone. You're going to ask your mother to answer yes or no based on how she's felt over the last week on 15 questions. You're going to circle yes or no. Then you're going to look at page 2. And if you've circled a no, and in that particular question, the no is bolded, then that answer counts as a 1. And if at the end of those 15 questions, your mother has 5 or more bolded answers, that's considered a positive test for depression. So it wouldn't be at all unusual to give this over the phone and then send the results to your mom's doctor.
Okay, and
You
you
can
said
do
a
the test as
neurologist,
well.
you mentioned a neurologist that specializes in, did you say depression?
Dementia.
Dementia.
Yeah, it's not a geriatric neurologist. It's a neurologist who specializes in dementia, and they're very, very rare. There's not very many neurologists who do that. But your mom is where?
In Southern Nevada.
In Southern Nevada. So there should be, is she near, what town is she near?
St. George is where she prefers to go. She's near Las Vegas, but they try not to go to Vegas. So St. George, Utah is the next biggest on the other side that they'll go
Well,
to.
you're looking for where would there be a testing center for dementia. And so it's probably going to be at the medical school there, or you can contact the Alzheimer's Association for Nevada, and they should be able to tell you where the testing centers are. And that's where your mom would actually go.
Okay.
But if you noticed a sudden downturn in your mom following the death of her mother, I mean, my first thought goes to depression, you know, especially if she loved her mother.
Absolutely.
You know, if that was a very close relationship, then you're absolutely going to see the effects of depression. And your mother is also in the age group of people most likely to have depression because they've buried their parents, they've buried a spouse, they may have buried children, they've buried siblings, they've had loss, they've lost friends, family. So they're in the category of people most likely to have depression and least likely to get treated for it. The geriatric depression scale, and I've already emailed it to Minerva, is the validity rating on it is like 98%. So you just fill it out and get it to your mother's doctor and ask them to check your mom. And handing them that scale says you're paying attention, so please check my mom. And then based on whether they give her generation 4 antidepressants, which would be like Effexor, 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 versus a Zoloft or a Prozac, which is a generation 3. The generation 4 medications go to work in a couple of days. The generation 3 medications may take 6 weeks to work.
Oh, wow.
It's hard to take a medicine every day, waiting to maybe feel better sometime soon in another month. It's just hard to do. So you might also talk to the doctor about, after meeting her, does the doctor feel that there's a medication that would work faster on your mom?
Okay. She has a lot of
Also don't forget to check for pain.
Okay.
Chronic pain, and for that you would use the pain ad, and that's you'll Google all capital letters PAINAD and make sure that the doctor is looking at her using a pain ad and not taking her word for she doesn't have pain. Okay.
Yeah, I remember you
You'd
mentioning
be
that.
amazed how many people we see with arthritis diagnosis, osteoarthritis diagnosis, rheumatoid arthritis diagnosis, and no pain medicine, because she's from a generation of people that did not say, I'm in pain. You didn't get any help for being in pain. Nobody loved on you for being in pain. You got smacked for whining about pain. When I grew up, I literally could drag into my grandmother's ranch with my arm hanging by a sinew. And my grandmother would say, I've had worse places on my eyeball. So they're not honest about pain, not because they're being dishonest, but because their whole generation was taught not to discuss pain, not to whine about pain. Okay.
All right. Thank you.
You betcha.
Thank you for getting us started, Leanne. For those that just joined us, we are asking Dr. Tam questions about our caregiving journey. This can be personal, as you heard Leanne there. Tam wanted to give you a chance to ask questions if you've been with her before. She does presentations and they're glorious and they're wonderful, but sometimes you can't get in and get your question asked. So this is your opportunity. Okay, Minerva, you said you have questions.
Well, tying it all with a depression and also being that we're getting into the holiday spirits. If someone is been diagnosed with chronic depression as they get older, how are they able to tell the difference between it being from depression and being able to tell that it's from a cognitive situation going on? And then my second question was, do they suffer also from the holiday blues?
From the
Or do
holiday
they?
blues?
Yes.
Okay, so holiday blues would sort of depend on how progressed is the dementia, because there's a point in time, Minerva, where the person with dementia doesn't have any concept of what day is or what time is or what season it is. There's no more memory of those types of things. So a person earlier in the disease may be having the holiday event in their home, and what the family notices is that he or she is more agitated or they're more withdrawn. The family that's not visited for a year because of distance or whatever may notice that grandma suddenly reached across the table, took somebody else's food, ate everything without waiting for people to even sit down, and then went to her room and took a nap. And so they may notice a difference in behavior, but we don't normally associate people who have more advanced dementia of having sort of that holiday blue spirit or holiday letdown. In terms of a cognitive disorder versus depression, ruling out depression is one of the tests as you move towards making the dementia diagnosis. So not only are they doing blood work and an MRI and a CAT scan, a PET scan, an EEG, an EKG, a SPECT scan, neurocognitive testing, the SLUMS test or the Montreal test, they're also ruling out depression via the geriatric depression scale. So depression has to be ruled out before a dementia diagnosis can be properly made. Does that make sense?
Yes, it does. Thank you.
You're welcome. I've also known Minerva 15 years. I've known everybody 15 years.
That's right.
Uh-huh.
So if you want to leave, the chat box is there if you choose to use it, but we have a small group today. So if you want to leave your mics open, that's fine. Guinevere, I see that you have a question or a situation you want to talk about.
Yes. Dr. Tam Cummings, I've been with you since 2018.
Long as I have, probably.
Yes. But without you and all the rest of the team and the members, I could not do what I'm doing. My situation, as I've told before, my husband was in military intelligence, high military intelligence, which I did not know. Things started changing at home, and so he went in for an appointment. The first time this lady doctor saw him, she tested him. She gave him that test where you answer the questions and you repeat the words, the 5 words and all this. And she rolled her stool up to me and she said, "Your husband has dementia." And I'm like, dementia, because I've heard of it. I didn't know what it was. So I started going to Lackland Air Force Base here in San Antonio, Texas. And I went there for 6 months every Thursday from 2:30 to 4:30 to get a handle on what was told. But in the meantime, they were scheduling him to see a neurologist. And when they did the neurological testing, it said that he had Alzheimer's. So that's my background. At this point, and I've said it before, Dr. Tam Cummings, we kind of laughed about, he's gathering and hiding. And I made a statement. I said, don't get caught up in your own in your own little circle. So then he started bringing the stuff back wherever it was hid, wherever it was. So he was gathering, hiding it. Now he's bringing it back. And it's my things, my clothes, my shoes, my personal things that I haven't seen in years. And then it's excessive cleaning. It's not the kind of cleaning you want the darling maid to come into your house to do. I could do that. It's taking off furnishing, paintings, destroying things, just scratching up things, those type things. And now it's more slipping out of the house without the chimes on the alarm system going off. But if I go in and out the door, they go off when I open the door, they go off when I come back in the door, but he's in and out and there's no sound. So I know he was in Vietnam. They told me that, exposed to Agent Orange and all of that. And he had 3 siblings, 2 in the same year died of dementia, 2 brothers and 1 sister. And he's in total denial, and the family is in total denial. So I just want you to understand, that's where I'm coming from. I can tell people that you can learn a lot by going to class. And the only way I got it well made is because it got to the point, the 6 months that I stayed at Lackland's Women's Support Group, he would figure out when I was coming home, when I was leaving time frame, and I'd come home and everything was just messed up, jungled up. So then they told me, they said, Guinevere, join WellMed. And they started sending me all this information, and I joined the next day. So I've been on here ever since then. And they tell me it's a special case. Now, what that means, I have no clue. All I know.
I'm gonna tell you what it is. Okay. He doesn't only have Alzheimer's, he also has what is called a toxic dementia because of his exposure to Agent Orange. And that's why you're getting these behaviors that you're getting. And his medication is going to need what sounds like an antipsychotic added. So you've got several things happening. Okay. First of all, he doesn't just have Alzheimer's. Okay, we know now that Agent Orange causes a dementia, so that falls under toxic dementias. He was exposed to toxins, and that effect is now what you're seeing in his brain. Some of the things that you're seeing him do are common things that people with dementia do. He's hunting and gathering. Okay, they pick stuff up, they move it somewhere else, they hide it, they find it later, they bring it back. But on top of his hunting and gathering, is a career spent in military intelligence, and military intelligence usually means we're hunting and gathering secrets. We're hunting and gathering information. So you've got an overlay of what his business was, what his profession was, on top of hunting and gathering, which is a normal part of dementia. Now he's not in denial, Mrs. Dockett. He's not in denial. This is brain damage, and the brain doesn't realize it's sick. So it looks like denial, it sounds like denial, but it's not actually denial. That takes a 3-pound brain. And from what you're describing, his brain has got significant damage, but then he's of a higher intelligence. And there's certain groups of people that when they have dementia, it just scares the bejeebers out of us. And let me explain it. If you are a nurse, you were born to be a nurse. You're supposed to be a nurse. And if you get dementia, you will continue to be a nurse, and you will drive us crazy because you will keep trying to get behind the nurses station. You'll keep trying to do nursing stuff. If you're a teacher, you drive us crazy because you keep teaching. You keep turning lights on. You keep trying to herd people into a group so you can teach them. If you're a banker or a CPA, a math teacher, you drive us crazy because that thing that drew you to numbers is your ability to focus and think analytically. And so it's very hard for us to outthink your damaged brain because you tend to stay more focused on it. When you take somebody of military intelligence, they have that more analytical brain. And so they do things that to other people sound like, well, he can't really have dementia or he wouldn't be able to do that. But you have to understand that before any of us had an alarm system in our house, your husband had an alarm system where he worked. And while other people with dementia wouldn't understand the alarm system, your husband was in the one profession that had alarms before anybody else did. They had cards that had to slide, IDs that had to be done, numbers that had to be pressed in. So he's turning the alarm system on and off. And how he's doing that is just fascinating because he's got pretty significant brain damage based on the other stuff that you're talking about. So you're describing somebody who has mixed dementia. And when you could see the VA doctor again, I would bring up that my husband was exposed to Agent Orange. We know that Agent Orange causes a toxic dementia. And you're gonna probably need to talk about antipsychotic medication to try to control this behavior of his. And when they start leaving at night, when they're doing the things that that you're describing, it's also time for you to be talking to the VA about placing him in VA care, because you can't protect him at night. You eventually will fall asleep, and your own health is at risk because of the amount of care that he's requiring. So I would definitely want to get it on the books that he was exposed to toxins, and you're concerned that he also has a toxic dementia. And I would really consider that it's time for placement for him, because you're certainly describing someone who should be in memory care.
Yes.
Okay.
You mentioned that the last time you said that it was time to seek memory care.
And
You
how
said-
long ago was that, Mrs. Dockett?
He
I will
first
drive
went
to
to the-
San Antonio. I'm not afraid to drive to San Antonio. I took a 6 and a 4-year-old great nieces to San Antonio. I told them we were in Europe. I'm not afraid to come to San Antonio and find you. It's time for him to get
Watch out,
to.
Guinevere.
He's in a city that has really good VA care because of the military post and bases there, and it's just time. Somebody's got to be the survivor of this disease, and it needs to be you.
Yes.
Okay. And given what he's been exposed to, it wouldn't surprise me that your own safety is a risk factor. I really, Glenda and I have talked about you afterwards without knowing your name, but we've been concerned about you before. As you shared information on here. So I really encourage you. You have been doing care for God knows how many years, and it's time for you to seek other help.
I appreciate that. Are you familiar with Barbara McNabb?
No, ma'am.
Okay.
I live in the middle of nowhere. Glenda will tell you there's nobody near me. I barely know anything, and I only speak Texan. So no, I don't know many people.
Okay.
She is out in the middle of nowhere, Guinevere, but she knows how to get to San Antonio.
Well,
For sure.
like I say, Doctor, I have your phone number, and I will be calling you.
Okay, and also you mentioned he's destroying items, and that's also a sign for the need to talk to the doctor about an antipsychotic medication. The doctor needs to understand he's being physically aggressive. Okay, it's not a bad thing. It's nothing he's doing on purpose. It's what they sprayed him with in Vietnam. It's their fault.
Yeah.
Okay, it's nothing he's
I
doing on
understand.
purpose. Okay, nothing he's doing on purpose.
You've been a big help.
Thank you, Guinevere, for sharing your story. It's touching.
Yes.
Those of us that are listening to it. Thank you again. Darlene, did you have a question or a comment?
Oh, yes.
I'm very.
Thank
This is the first time this is the first time I've heard anyone address certain behaviors dealing with military people going through. Well, she didn't say PTSD, but some of the things that you were talking about was reminding me of that my husband do have PTSD. He attacked me in his sleep around my neck, and the VA didn't do anything about it. he told them that he did it, but they never addressed me on it. And just to hear you say that, I thought it was something wrong with me by even addressing that, although it doesn't have anything to do with dementia at this time, but I just want to thank you.
Well, but you're absolutely right. And thank you and Miss Dockett for your service as a spouse of a soldier or a military person. Thank you very much. I have an ex who's an ex-colonel, and I can tell you that people who have been to war, people who have been exposed to what our military people have been to, you better be very careful in the night waking them up, because it can be a risk to your own health. And so that certainly, you could start a support group of women who've been attacked by their soldier husbands in the middle of the night during a dream or during a movement or whatever was going on with them. And there hasn't been a study connecting PTSD to dementia. We know now that we're looking at really high numbers of PTSD, because we know that the staffs in our communities, the results of their work during COVID with the deaths that they had to deal with, the illnesses they dealt with, and then the fact that you couldn't see COVID coming. It was like what we'd learned in the Iraq and Afghanistan wars. The other soldier didn't wear a uniform. I could be standing next to you giving you COVID that's going to kill you. And they had to work under those conditions. So we know we've probably got an awful lot of staff members who are professional caregivers who now have PTSD. And we know that if our military people don't get treatment for it, it doesn't help. But so far, there have not, to my knowledge, been any connections between PTSD and dementia. But we know there are connections between untreated depression and Alzheimer's. So it would make sense to me that somebody's probably going to write a grant to connect PTSD to depression to dementia, or PTSD to dementia. But I haven't seen anything just now.
Thank you.
Thank you, Darlene.
And I'm glad to hear her say what she said, because dealing with the military and the civilian doctors, it's a total different thing. They kind of like you're not in the room. They're there for the person that did the service.
Yeah.
That's what I get. Yeah.
Mm-hmm.
Yeah.
And you have to make sure that if I go to the doctor with my person, I can't sit next to them. I've got to sit back out of their peripheral vision so I can do this and this, and hopefully get that doctor to pick up on a cue of what's going on. And you're absolutely right. They could give a crap less about you. You didn't serve. They are only there looking at that person who wore the uniform. So a lot of times we're not going to get assistance or help back from them. And that's because of how that system is set up.
Thank you.
Thank you so much, Darlene and Guinevere, for that. Catherine, I see you have your phone unmuted, but let me look over here at our chat box. This is from, and pardon me if I mispronounce your name, Nargis. She needed to know about caregivers sometimes get offended if you suggest long-term care placement or skilled nursing facility as an option. Yes, we've seen that a lot over the years, haven't we, Tam?
Who is she saying gets upset?
The caregiver sometimes gets offended if you suggest long-term care placement.
Oh, yeah. They see it as a failure on their part. Absolutely.
Yeah. How would do you have any tips for her? I'm getting the impression from her chat box that she is a professional counselor.
I frame it as this is a medical disease that now requires medical care. I frame it as if this was cancer, we wouldn't even have this discussion. I would say it's time to move your person with cancer. I explain it as, imagine you take your mother to the general doctor, and in 5 minutes, the general doctor says, your mother has cancer, come back in 6 months. And you say, okay. And in 6 months, you come back and the doctor says, well, your mother has cancer. It's time for her to go to the cancer place. And when you get to the cancer place, you notice that everybody there has cancer. That's all they have, just cancer. But one person's face is rotting off. One person's leg is rotting off. One person's got a hole in their stomach. One person's missing a breast. But all they will tell you is they all have cancer and they're all on the very same medication and dosage. You would say, that's crazy, get me out of here. Yet that's exactly how we have treated dementia. Rather than recognizing that these are brain diseases and the type of dementia a person has determines where it starts in the brain and where it's going to go to next, which is what allows us to build staging tools. It's what allows us to tell you, here's the behaviors this dementia is going to have. Because if I poked Glenda in that same area of the brain, she would do the very same behavior your loved one is, because that's the area of the brain that controls that particular behavior. So a big part of it for me is that comparison between cancer and dementia, that they're both umbrella terms. The cancer family is a caregiver 2 years, the dementia family is a caregiver 10 or more years. The cancer family understands to ask questions: which cancer, what stage, is it treatable? Are my children and grandchildren at risk? Is there medication, radiation, treatment, therapy? Where will we go for care? The dementia family has no idea those are the same questions they should ask. The cancer person has an expectation of a miracle because everybody here knows somebody who was supposed to die 10 years ago and didn't. In dementia, there is no miracle. When the person with cancer dies, the family has no measurable levels of guilt. When the person with dementia dies, the family has a huge level of guilt. And the number one answer they give is, I didn't do enough. Yet I know the day I meet them, they've been doing care at least 10 years. And Glenda will tell you the day she and I meet someone, the caregiver looks worse physically and mentally than the person who has the terminal brain disease. And then I frame it not as dementia, but as a medical terminal disease of the brain that now requires medical care that only comes from a licensed, skilled facility or memory care. Those are the people that are licensed and trained to do this type of care. And when you begin to phrase it as, think of it as brain cancer, people have been trained to think about cancer differently. And we know, Glenda, that if you fell down at my house and I called EMT and they came to the house and I said, she has dementia, be careful, they'll actually be rough with you. But if you fell down at my house and EMT came and I said, be careful, she has brain cancer, they would treat you like fine glass. There is a stigma about dementia and families don't understand. We're not talking about putting you in long-term care because we're mean. We're talking about putting your loved one in long-term care because they now require medical care. And all research shows people with dementia get better care in a community. The people there are trained to spot strokes, delirium, UTIs, range of motion after falls. The X-ray comes here, help is immediate, and they're trained to do care in the aging, and you're not. And so that's, I explain it very much like that. And I finish with, if it was cancer, we wouldn't even have this discussion. I would simply say it's time. So try that and let me know how it works.
Yeah, Tam's the first one, and she agrees with you, that I've ever heard in all my years in work with aging that made it so clear to me about how dementia should be looked at as a disease, as cancer, instead of some mystical, horrible thing that happens.
Witchcraft and voodoo, Glenda.
Yeah.
Witchcraft and
Yeah.
voodoo. They're doing it on purpose. No,
Yeah.
they're not. They're simply
Exactly.
responding to brain damage.
Exactly. Catherine, you've been so patient. Please go ahead.
Okay, thank you. Dr. Tam, I've asked you this question before, but for the life of me, I can't remember the answer. And is dementia hereditary? My mother had dementia for many, many years, and we took care of her until we couldn't. For her last year, we put her in a nursing home. But I was curious if it's hereditary, because her sisters also have gotten it and have died from it.
Okay, so first of all, you didn't put her in a nursing home. That sounds like you got rid of her. You took her to a skilled facility for care.
Yes.
For the final part of life. And y'all were such a good family, such a dear family, that you were able to gather forces and take care of her until that final moment. But you didn't put her anywhere. You took
Thank
her
you.
for care. Okay. Are you Hispanic?
Yes.
So our Hispanic Americans and African Americans have the highest groups of vascular dementia. And when a family comes to me and says, you know, my family has dementia and my mother's dementia and her sisters all had, I don't think Alzheimer's, I think vascular, and the vascular is based on diet and exercise. Historically, African Americans have had a diet higher in fat. And because of, and this sounds so terrible to say, but it's because of lard used to make tortillas and lard used to make refried beans. That heavy fat diet in Hispanic Americans caused that push up into vascular dementia. So when I look at Hispanic American, African American families, and they report this thing of a set of the families seems to have dementia, their first fear is, oh my gosh, it's Alzheimer's, when what it probably most likely is vascular dementia caused by diet and exercise, which are, as we all know, the two ugliest words in any language, because it means a heart doctor gave me the diet once. Do you want to know the diet?
Yes.
If you put it in your mouth and it tastes good, spit it out.
Oh.
That was the heart doctor's diet, which basically leaves us eating rice cakes and seaweed, which technically don't taste good, but at least it's green. So it really comes back to honestly take a look at your mom and your aunts and think to yourself, are they obese for their size? Is there a history of high blood pressure in my family? Do I have high blood pressure? Do I have high cholesterol? You can be this big around, run marathons, but inherit high cholesterol from your mom or your dad. Okay. And you've got to find a cardiologist that's going to listen to you and take you seriously, because remember, these are the physicians that go, yeah, women don't have heart attacks. Yeah. So what do they know? Turns out we're humans. We have hearts and we have heart attacks too. We just have it in a different way. But make sure you get a cardiologist. I would look for a female. No kidding.
Okay.
No kidding.
Okay.
And I make all my doctor's appointments at the end of the day. You know why? My doctor doesn't have to see anybody after me. So I get undivided attention, and I'm usually in there for 45 minutes or an hour, and I'm healthy. It's just we're going through, I want everything. So make sure they're listening to you. Go back and look at your family history. Is your mother 4'11" but weighs 200 pounds? Is she obese? Your aunts. What do you see in the similarities? And what happens is when the 23 DNA came from your daddy and the 23 DNA come from your mama, from the egg, those went together and that unlocked the blueprint for you. Okay. And for each of your siblings. So the same thing happened with your grandparents and your mama and her sisters. So you could have, that was a bad blueprint. And so every single child has an inherited form of vascular disease. Or you could go with the blueprint was fine, but the diet and exercise affected us. So take an honest look at yourself. Are you working out? Are you in good health? Are you drinking lots of water? Are you doing all those things? And then be real honest about your aunts, and then go back to great aunts or great uncles and look and see on that same side of the family, or is it in different sides? And then make sure your doctor does a full physical. Tell the doctor, I'm afraid I have vascular dementia all in my family. Please check me and make sure I get referred to the cardiologist to get the full workout. And then we come down to the two ugliest words, diet and exercise.
Got it.
I sadly began to look in the mirror last week and made the decision that I too must join the diet and exercise group.
Yeah, that's all of us.
Yeah, that's all of us. That's true. Thank
It
you.
really is. We evolved. Our grandparents walked between 8 and 20 miles a day. We move 80% less than our grandparents. So we got to move more, park in the far end of the parking lot. Have you ever watched those people drive around and around the parking lot? If they'd just park by now,
they just
done. Park away and walk. Add walking everywhere you can. Get a Fitbit, get a Apple Watch, get something that measures your stuff on how you're sleeping and how much movement you're doing. And what you'll find out is as we age, we've got to add in more movement. probably yoga and Tai Chi. That's really, and as part of those comes breathing meditation. And those are the things that are going to help us age best.
Okay, awesome. Thank you so much.
And I love your
Appreciate it.
glasses.
Oh, thank you. I love yours.
Cool.
Thank you.
I don't want to let y'all miss that Nancy had put in the caregiver support program for VA, and please make note of that web address if you are involved with someone that has VA benefits. Darlene, you had your hand up.
Yes, and I forgot my mic and I made all that noise. I'm sorry.
It's all right.
Dr. Tam, you are the most honest and telling the truth, because as I think about my generation, I work with Alzheimer's and dementia program here in my city, Valdosta, Georgia, actually a day program. And I was able to see the things that you were saying about addressing them, knowing them, you could see some of the things that they were going through, and you were able to say, this is what's going on. And all of that was in my head, but I couldn't express it because I didn't have Dr. Darlene Myers behind my name. And that's sad to say, but I was understanding what was going on while I was actually working in the program. We do need more students, more young people to be trained in dementia and Alzheimer's. I wish they were able to do it. And I worked on the VSU, college, a university, and I was able to get some students in there, but they were all afraid. And the main question is, are they going to attack me, or are they going to remember this? Can they do this? Can they do that? That person is still there in a different way. And that's what I try to express to people around me about dementia now. I just want to say that, yes, I am beginning to work more, staying away from fatty foods, staying away, doing more vegetables and fruit, because I do have hypertension, and my mother had dementia, and her grandmother had dementia, and her sister had dementia. I don't want that to happen to me, simply because I was eating the wrong food.
My family doesn't have dementia, but we have an extraordinary number of people that drop dead at 40 from hypertension. So we simply don't live long enough to ever develop anything. But my family definitely has that cardiovascular DNA thing. We've got it. And on top of that, I grew up on a ranch where every single day we ate fried steak and French fries. And that was our deal. I don't think I really saw salad. My mother says this isn't true, but I don't think I saw salad until after college, maybe. But it is diet and exercise, and it is all of us. When I read the stuff about, it's African Americans, it's Hispanic Americans, I look around and I go, no, it's Americans. It's all of us. Our grandparents ate 1.5 pounds of sugar a year. Today's teenager eats 154 pounds of processed sugar a year. We got candy once in a blue moon. Today's kids get candy in their lunch. I mean, it's incredible. We don't move as much. I know of college students who have told me they have tried to figure out how to keep their steps to a minimum. At a time when it's the one time in your life nothing in your body hurts, they're trying to walk less. And the reason that we have this great generation of people in their 80s and 90s is because they did walk everywhere. And they did have to do physical stuff. And that has become less and less and less part of our world. And I don't like salad. But Glenda, I'm trying. I find that I can look at one now without becoming sick. So I'm getting better. I can make eye contact.
Do not spit out that lettuce, okay? Swallow it.
No, I'm doing what that doctor said.
No. Oh my goodness, Tam, you always make me laugh, but you have such good information. Let's see, we have about 10 minutes left. Are there any other questions You want to talk about your particular situation in your caregiving journey. I know Tam would, and you've seen some wonderful examples today, and I am so thrilled that, you know, Darlene, Guinevere, Leanne all told their story. It impacts others for sure. Well, while people are thinking, Tam, this is the age-old question that I always ask you, and you always answer it so well, but I think it's so important. Why is it important to get a correct diagnosis as soon as you can when you're dealing with dementia?
Because the sooner the medication is started, and it's intended to be started in stages 2 and 3, the greater chance the person has of living into old age without ever developing dementia to the point where they would need to be in a community. Number 2 reason is there's 100 common things that would make a person look and feel as though they had dementia, cognitive issues that are actually treatable. They're a hormone out of balance, a vitamin out of balance. Depression is the number 1 thing, untreated chronic pain. Think about, I don't know about you, Glenda, but women in my family have cramps. And I can promise you, when we had cramps, we were not pleasant people. And not only were you not pleasant, you couldn't even remember. You hurt so bad. So pain is a big issue. Untreated anxiety is a big issue. And how many of us don't feel anxiety or depression these days? We're under a great deal of stress. I read the other day the most horrible thing. It was 1/3 of the country wants to kill 1/3 of our country while 1/3 of our country watches. And that's the same belief that happened in Germany to get Hitler into power. So it's just, we're at a scary time. We're coming out of COVID. Maybe we're fixing to go back into COVID. I don't know. It's all frightening. And then each one of you is doing care, or you're assisting with care, or you've been a caregiver. So your stress level is even higher. So you just got to remember to take care of yourself. Go to self-compassion.org on Dr. Krista Neff's site. It's self-compassion.org. Scroll down, take her test, find out that you're not nice to yourself. I took that test, Glenda. You know, the top score is a 5. I'm kind of a overachiever. I'm pretty sure I'd score a 6 or a 7 on it because top score was a 5. I scored a 2. A 2 means I'm barely breathing above the level of an amoeba in terms of taking care and being nice to myself. And we know that for professional caregivers and family caregivers, you give so much to your loved one that there may not be much left for you. And so you need, I beg you, go to self-compassion.org, take Dr. Neff's test, and then start doing things to be nice to yourself the same way you do for everybody else. In social work, they taught us that we couldn't have empathy if we didn't go back home and refill our empathy. And for some of you, you may have to do care at home for a longer time than you intended because of finances. But if that's the case, we still need you to survive. And the way you can do that is through respite care, which means that your loved one goes into a skilled nursing facility or an assisted living or memory care for about 2 weeks, and you don't visit. The point's not for you to visit. The point is for you to get rest, clean your house, go see your kids, go see your grandkids, go see a play, go to a movie, go out to dinner, wear a mask, be careful, but for you to get your feet back up under you. And for some families, Glenda, this is going to be the way they navigate care because the cost of this care is so extraordinary.
It's true. It's true. But it's essential.
Mhm.
It's essential for caregivers for sure. Anybody think of a question or a situation they want to talk to Tam about? This is such a wonderful, unique opportunity. Okay, so the next thing I'm going to ask, since people are still thinking and we have about 5 minutes left, we hear a lot recently about medications for Alzheimer's and things that are being brought onto the market. Can you talk about that a little bit? And what are they designed to do?
They're designed to do the same, pretty much similar to what already is out there in terms of Aricept, Razidine, and Exelon. They're intended to be started in stage 2 or stage 3 of the disease. And it's the same thing with the hopes that it would slow the disease down enough that the person could age without that massive loss of brain tissue that occurs otherwise. There are, I believe, about 100 trials going on worldwide. There are several. There are less than a dozen that I'm aware of that are in human trial. One of them is actually here in Austin, Texas. Dr. Bertelson and Dr. Winston are doing a joint medication trial. So there's stuff going on everywhere. But Glenda, every year I read and I hear that in about 5 more years, we're about 5 more years. And that's been about 25 years now. We've been about 5 more years. So we're about 5 more years, everybody, 5 more years, 5 more years. And if you have found the book from the guy that says he can reverse dementia, what he's talking about is simply not true. We have no way to regrow brain tissue. We have no way to make this disease stop. What he's talking about a lot is diet and exercise before dementia ever even begins. And remember, we know now, before we see dementia, we see depression. So I sent Minerva the geriatric depression scale. When you do it for your loved one and finish, go ahead and take it for yourself and then go see your doctor, because there's no way that you have not been affected by care during COVID. I mean, the death rates went up during COVID because of the amount of care you do. So be sure, just like on the airplane, you got to put your mask on first. So go ahead and take the depression test. It doesn't mean you're lazy. It means that you're human, and the effects of the disease on your loved one have taken a toll on you and your mental health as well. And that's to be expected. You know, Glenda, you and I always talked about the ones that scared me were the ones that didn't cry. Those were always the family members that scared me, because if I explain this and it doesn't affect you, something's missing.
That's right. Well, Nancy wanted to know if your book is still, I know that's backwards to y'all. This is
that book has not. Yeah, that book has not been available for years. That book is now a book called Untangling Alzheimer's, and it's in red and white with a white yarn heart on it and a pair of younger hands holding a pair of older hands. I also have just published a book called the Itty Bitty Dementia Book, which has all the tools you need in it. And if you can't get enough, you can also get a copy of Becoming Dementia Aware, which is the professional workbook that goes with 12 hours of video training. And that book is intended for professional caregivers. But if you're a family doing care at home, it certainly has information you would need in it as well.
Are those available on your website?
No, my website's actually about to come down and be redone as we stand up the Dementia Association website, but they're available on Amazon, from Amazon Books or wherever books live on Amazon. That's where they live.
Okay, Nancy, I hope that that helped answer your question. A lot of information, new information that Tam's been working on. I just had her older book out because it still has a lot of good information, and she dedicated a little part of it in the beginning to me because I helped proofread it. Anyway, Darlene, do you have a final question or comment for us?
That was my question. How can I find her again? I don't ever want to lose you.
I'm with you. I never want to lose her. And what I will do, Darlene, if you register for the call today, then we will have a follow-up email that's going to come out to you. We're going to list the things that Tam talked about. We're going to give her a website. We're going to give her a telephone number. Even though she says the website will be coming down, it'll probably have a link to the new website eventually. So take advantage of that. Tam really does like to hear from you. So if you call her, leave a detailed message, and she may not answer, but she will get back with you. Guinevere knows because she's going to call her if she hasn't already. So
I will.
Okay. Yes,
I sure will.
Do that. She's looking forward to it. But remember, she knows where San Antonio is. So Nancy says, no one has helped me understand dementia like Tam. Absolutely. I couldn't agree with you more. Tam and I have been working together, 15 years maybe. And I learn something new every time I'm with her. And it's easy for me to understand. There's no smoke and mirrors. There's no curtains that need to be drawn back. She helps us see it like it is. And I think, Darlene, you said that. She's so honest about it. Yes, it hurts. Yes, it's sad. Yes, it's depressing, but it's factual and you can trust it. So that's my word.
You know, it's all it is the same thing we do for cancer. That's all it is. You wouldn't leave the cancer doctors until they set you down and explained it to you. And what you guys get is it's dementia goodbye.
Yeah.
And it's just so wrong. It's so terribly wrong. So everybody hang in there. You really can call me. If you write me, I'm just going to say, call me. So call me.
So we won't even bother with the email address. We'll just give you the phone number, okay? Minerva reminds you that you can listen to Tam's previous sessions by going to the website and listening to her podcast. You're never alone. She's there because you can reach the podcast 24/7. So she's always there to answer questions. I can't tell you how much.
Want to know a secret, Glenda?
What's that?
If you got the book Becoming Dementia Aware and went back through your podcast, you could match each podcast to the chapter of the book it goes with. Just don't tell anybody.
Oh, that is a big secret. Yeah. All right. We had a small group today, but I couldn't be happier with the results, Tam. Everybody was interactive and we had a good discussion. So I want to thank you, Tam, as always, for being with us. I want to thank each one of you for what you do in your caregiving journey, whether it's a professional like Darlene or someone like Guinevere that's in the trenches every day, 24/7. Who's going to look at long-term care options through the VA real soon. So I hope that you'll come back and be with us again. I will actually be back with you this Monday at 10 o'clock Central Time. Dr. Elliot Montgomery-Sklar and Samara Yekovich are going to be back with us, and they're going to be talking about modern caregiving for modern millennials. I don't know if any of you work with millennials. It's a whole different situation there. So thank you for being with us today. Stay healthy. Watch for that follow-up email. It'll be out in a couple of days. And thank you for being with us.
Take care, everyone.
Bye, Darlene. Bye, Guinevere. Bye, everybody.
Bye. Bye, Guinevere. I'll bring Glenda with me. Be aware.
I'll come, Guinevere.
Bye.